Good evening, each and everyone over here. I am thrilled to welcome you all for today's informative webinar on Hemoptysis Made Easy. I am Vijay, a manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker, Dr. Sohail Mohammed. Dr. Sohail is an accomplished respiratory medicine specialist and an academician, currently serving as assistant professor at Al Amin Medical College, Vijaypur. A university rank holder in MD Respiratory Medicine from RGUHS. He has also earned top honors, including first prize in 34th PURVIEW quiz conducted by CREST. He previously served as assistant professor at Kanchanur Institute of Medical Science, Mangalore, and is also an active contributor to medical education as a CME speaker and postgraduate presentation moderator. Dr. Sohail's work reflects a strong commitment to teaching, research, and advanced respiratory healthcare. Over to you, Doctor.
Yeah. Hi, Vijay. Can you see me and can you hear me?
Yes, yes, Doctor. We can see you.
Yeah. Yeah. Thank you. Thank you very much for this kind information. And let us begin our today's live webinar without wasting much time. I'll just try to share my screen.
Yes, Doctor, please.
Okay. Is it visible?
Your screen is visible, Doctor. Yes.
Second.
Yeah, PPT is also visible now.
Yeah. Okay. Okay. So let us begin. Thank you. Thank you, Mediversal Academy, for organizing this live webinar. Topic Hemoptysis Made Easy. Shall we start, Vijay?
Yes, Doctor, please. Yes.
Yeah, okay. So today's topic is hemoptysis. So when we hear hemoptysis, the word, it it is an alarming word. It makes us alert. So whenever we hear over the phone or whenever we see a patient telling a patient had blood in the sputum, it is a kind of alarm which rings in our brain. So we have to be alert and we have to be very careful with this symptom and with this patient. So today we'll see how to deal a patient who is having hemoptysis. So when the cough turns red, it's an alarming sign. So what we consider hemoptysis as a red flag sign while we are teaching our postgraduates or who are doing the respiratory medicine graduation. So we tell them hemoptysis is considered as one of the red flag sign. So in that, there is usually a symptom of blood in the sputum. So here is one case. 32-year-old man coughs up a teaspoon of blood. Should we panic? Just a teaspoon of blood. Okay. And there is another person who is a 60-year-old smoker, brings a cup half filled with bright red blood. So these are the two different scenarios, what we see here. First scenario, just a teaspoon of blood. And the second scenario where there is a half cup filled blood. So there are two different scenarios. So hemoptysis can present as a streaky without any risk factor, or it can present in an elderly smoker with a risk factor and a significant amount. So let us deal and decode one by one in our subsequent slides. So you can see here the second, yeah. So this is how the streaky and this is how the second patient is presented, okay? So can anybody tell, is this hemoptysis or hematemesis? Because when the patient tells blood in the sputum, we have to differentiate hemoptysis and hematemesis because these are the two things which are most confusing. Okay. So there is one more image. This is a second image. You can see carefully. And this is a third image. Okay. So let us see what are these images. So whenever there is blood in the mouth, we should know the location where it is originating from. If it is mainly originating from the lungs, then we are going to call it as hemoptysis. That is a true hemoptysis if it is from the lungs. If it is from the upper airway or it is from the mouth, we are not going to call it as a true hemoptysis. It's called as spurious hemoptysis. And if it is coming other than airways, or lungs, that is from the GI tract, that is stomach. And we are going to tell it as hematemesis. And how to differentiate? So it's a frothy and bright red. It is frothy because it is mixed with the sputum, and it is non-frothy because it is mixed with the saliva. And here it is dark red. And sometimes there will be presence of food particles. So blood in sputum is not always from the lungs. You have to look the color, content, as well as the context. Hemoptysis being a small sign, but it has a very big implication. So I already told it is an alarming sign, which is common or frightening and often a misunderstood symptom. 80 to 90% of these cases are reported to be mild, but in that case, again, 5% can be fatal. And this symptom is often judged wrongly. It can be infection, or sometimes we think of cancer, sometimes we think of vascular bleed. So we should know a systematic approach to a patient who is coming with a hemoptysis. So that is what today's live webinar is all about. We have to recognize, approach, and manage the cases, and we'll end with some special cases. So before going to the hemoptysis approach, we should know what is a definition. What is the exact definition of the hemoptysis? Hemoptysis is the expectoration of the blood or blood tinged sputum from the lungs or a tracheobronchial tree. As I already told you, it is blood from the lungs or a tracheobronchial tree. Hematemesis is vomiting of the blood. Okay, it is not coughing. It is vomiting of the blood, mainly coming from the GI tract, either the upper part of the GI tract or the stomach. Spurious or pseudohemoptysis is the appearance of the blood in the sputum, that is along with the saliva, and that is mainly coming from the upper respiratory tract, that is the mouth, nose, throat, or upper airways, and it is not coming from the lung. And one important feature in this is the patient will not complain of cough. He will just tell there is a blood in the saliva. That is the differentiating point between true hemoptysis and a pseudohemoptysis. So this is the very important table where I am comparing hemoptysis, spurious hemoptysis, and hematemesis. As per the definition, it is coughing off of the blood from the lungs or tracheobronchial tree. In spurious, there is blood in the sputum from upper respiratory tract. And in hematemesis, it is the vomiting of the blood from the upper GI tract. So below the vocal cord is the source for hemoptysis. For spurious hemoptysis, it is above the vocal cords. And for hematemesis, it is the upper GI. The appearance wise is very important. You can see it is bright red because it is a fresh blood, which is frothy and mixed with sputum. Here again, it is a bright red blood, but not frothy. Okay, and it is mixed with the saliva, not sputum. Here it is dark red because it is treated with the acidic pH, and it is coffee ground color. That is what we tell, coffee ground vomitus, and sometimes mixed with the food particle. When we check the pH of this blood, it is alkaline in both true and the spurious hemoptysis, but it is acidic in hematemesis. Associated symptoms are also very important. The cough has to be preceded to call it as hemoptysis. Dyspnea and chest pain may or may not be present. In spurious hemoptysis, the cough is not there, but evidence of epistaxis or gum bleeding can be there. In hematemesis, the GI symptoms like nausea, vomiting, and abdominal pain. So very important point is this coughing has to be there. It is preceded by coughing in true hemoptysis. Whereas in spurious hemoptysis, they will be doing frequent clearing of the throat like this. So they will only demonstrate you. And in case of hematemesis, it is the nausea or retching or belching. And when we see the presence of clot is very much common in hematemesis, and it is less common in these two. Yes, it is possible in spurious hemoptysis. So how to confirm? The sputum examination has to be done in true hemoptysis, whereas ENT and oral examination to find the source of bleeding. And in this, acidic pH with the food or blood in the vomitus. So this is a very basic table to differentiate hemoptysis, which is true coming from the lung, spurious hemoptysis, which is coming from the upper respiratory tract, and hematemesis, which is entirely coming from the GI tract. So in the first slide, I have showed you hemoptysis can vary from a streaky or to a blood-tinged sputum, and it can be sometimes massive, where it can be a life-threatening episode. But it's even though it is a serious symptom, there is no obvious cause found in around 20 to 30% of the patients, which are even after complete extensive evaluation. So those are considered as idiopathic. And for hemoptysis to occur, the bleeding site, the pathology has to communicate with the airway. The pathological site in the lung parenchyma has to be communicating with the airway, then only the hemoptysis can occur. So before diving into the approach to hemoptysis, let us know a little bit about the anatomy. Any idea how many organs in our body are having true blood supply? How many organs in our body are having dual blood supply, true dual blood supply? Okay. So the answer is lung as well as the liver. These are the two organs which are having true dual blood supply. For liver, we have a hepatic artery and a portal vein. And for lung, we have bronchial circulation as well as the pulmonary artery. So these are the two organs which are having significant true dual blood supply. For liver, hepatic artery is mainly associated with the oxygenated blood and a systemic circulation, whereas portal vein is nutrient rich and it is a deoxygenated blood. Lung, bronchial arteries are the main arteries which are supplying the oxygen and they are systemic. Along with that, they will be supplying the nutrition. Whereas pulmonary artery, they carry the deoxygenated blood for exchange of gases. So the systemic supply, okay, this is very important. The systemic supply is by the bronchial circulation. So which one might cause a massive hemoptysis? It is a systemic one because the systemic circulation has higher pressure when compared to that of the pulmonary vasculature. So let us see the difference between the bronchial and pulmonary circulation. So bronchial circulation is originating mainly from the systemic arteries, that is the aorta and other systemic arteries. Whereas pulmonary circulation is arising mainly from the right ventricle. They have a functional role of supplying the nutrition to the lung. These are primarily involved in gas exchange, that is exchange of oxygen and carbon dioxide at the level of alveolar capillary membrane. Oxygen content of the blood, these are oxygenated content, and the only artery in the body which carries deoxygenated blood is pulmonary artery. Similarly, these drain into bronchial vein and then into systemic circulation, and they directly go to the left atrium with the oxygenated blood. When we see the pressure, of course, the systemic pressures are on higher side. So the bronchial circulation has high pressure and the pulmonary pressures are low. And what is the clinical relevance? The bronchial circulation, which is supplied by systemic arteries, are the common source of significant or massive hemoptysis. And that's why they are targeted for bronchial artery embolization. And these pulmonary vessel bleeding are usually of low pressure, with few exceptions, which will be discussed in the subsequent slides. So I hope I am clear about the dual circulation and the organs which are having true dual blood supply in the body. So before we approach to the to the hemoptysis and the control, we should grade. So the grading is not standardized. The grading differs in different books and different articles in different literature. So let us see what the standard article and standard literature tells us. When we see the mild or non-massive hemoptysis, it is less than 30 to 50 ml in 24 hours. When you go for a moderate, which is severe but not life-threatening, it is around 50 to 200 ml in 24 hours. Whereas massive or life-threatening is something which is more than 400 ml in 24 hours, or at one time, the patient is expectorating 100 to 150 ml. So it differs. Whereas massive or life-threatening compared to other books, it is more than 200 ml for 24 hours or 1000 ml per 24 hours. So it differs. So we can take a cutoff of 400 ml. Beyond that is considered to be as a massive hemoptysis. So there is no universal definition to tell it as a massive hemoptysis. The clinical impact, which is very, very important. If hemoptysis is causing airway obstruction, hypoxia, or hemodynamic instability, that is more important than the volume. So we should not exactly keep measuring the volume. We should see the other clinical condition. If the patient is having airway obstruction due to the clot, due to the aspiration, and leading to hypoxia or hemodynamic instability, that is far more important than grading the hemoptysis. So there are various etiologies. Let us discuss one by one about the hemoptysis. So first and foremost is infectious causes. So infectious causes are considered as most common causes for hemoptysis. In that, we begin with the acute bronchitis, which is a self-limiting condition which can be treated with oral antibiotics. That's a common cause for streaky hemoptysis, followed by chronic bronchitis exacerbation. Whereas in pneumonias, we have bacterial pneumonias, which are necrotizing ones like pneumococcal, Klebsiella, Staph aureus, or actinomyces and nocardia. TB, very important as a developing country, and incidence of TB is quite higher side. So cavity of the TB or Rasmussen aneurysm or post-TB bronchiectasis, or sometimes post-TB scar carcinoma. These are the causes for hemoptysis in tuberculosis, followed by structural lung disease or suppurative lung diseases where there is presence of thick expectoration or pus in the lung, that is bronchiectasis and lung abscess. They can cause inflammatory damage to the adjacent arterial vessel wall, and that can lead to massive hemoptysis. Non-tubercular mycobacteria, fungal infections, and parasitic infections are also contributor of hemoptysis. Whereas endemic hemoptysis, the paragonemiasis, which is called as lung fluke, is known to cause endemic hemoptysis. Neoplastic, yes. Whenever we think of hemoptysis in an elderly smoker, we have to consider neoplasia as one of the differential diagnosis. In that, bronchogenic carcinoma of any etiology is tend to cause hemoptysis. Other than that, we have carcinoid tumors and lymphomas, and sometimes this metastatic tumor from kidneys, breast, and colon. Rarely benign tumors can cause hemoptysis. And in HIV individuals, Kaposi's sarcoma carries a very high vascularity as well as chances of brisk hemoptysis. Yes, there are certain cardiovascular causes which are causing hemoptysis. So hemoptysis is not always from the lungs. Okay, so there are certain cardiovascular causes which can also cause hemoptysis. Among them, the first important is mitral stenosis, where the source is from submucosal bronchial vein. Because of the mitral stenosis and back pressure, there will be dilatation and submucosal bronchial veins are ruptured. And left ventricle sometimes can cause hemoptysis. Other than that, we have vascular causes like pulmonary embolism or infarct and pulmonary arterial hypertension, and certain vasculitis like granulomatous polyangiitis, microscopic polyangiitis, or Goodpasture syndrome, which are vasculitis. They can also cause hemoptysis, followed by aortic aneurysm, arteriovenous fistula, or Eisenmenger syndrome. So these are certain cardiovascular causes causing hemoptysis. Yes, whenever there is a mechanical or traumatic injury, there may be chance of bleeding. That can also happen inside the lung. So let us see what are these mechanical or traumatic causes. So it can be a chest trauma, blunt or penetrating, or a rib fracture, which is puncturing the lung directly, or it can be an induced, like ventilator induced due to pressure, high pressure, or when there is ascent, high altitude, pulmonary edema, sudden rupture of the small vessels. Sometimes foreign body aspiration or iatrogenic like bronchoscopy induced or lung biopsy induced or any kind of thoracic surgery that may also can cause bleeding, and that leads to hemoptysis. And sometimes when the patient is having uncontrolled and very severe coughing, there may be chances of mucosal tear, and that can also cause hemoptysis. Certain hematologic conditions. Yes, there are certain systemic conditions which can increase the tendency of bleeding, and there are certain drugs which can also increase the tendency of bleeding. So among them, the thrombocytopenia and coagulopathies can also lead to multiple site of bleeding, not just hemoptysis, but they can present with the hemoptysis. Iatrogenic, if the patient is on anticoagulant for the treatment of pulmonary embolism or antiplatelet therapy, or patient has undergone thrombolytic or anti-VEGF therapy, bevacizumab. So in these drugs also, there may be chance that patient may develop bleeding. Certain miscellaneous causes, in that the one cause is pulmonary endometriosis, where there is ectopic presence of endometrial tissue in the lung merenchyma or mediastinum that is associated with the menstruation, that is called catamenial hemoptysis. And we have pulmonary AV malformation. And since I have told in the beginning, certain studies have showed 20 to 30% of the cases where there is no cause despite extensive evaluation. So those are considered as idiopathic or cryptogenic hemoptysis. Okay. So these are causes of true hemoptysis. Then coming to the Spurious hemoptysis. Yes, I already told you the difference of true hemoptysis and spurious hemoptysis. Spurious hemoptysis is coming mainly from the upper respiratory tract. Okay, and it is mixed with the saliva and not with the sputum. So it is associated with epistaxis. Certain times in the postnasal drip, the bleeding from the posterior epistaxis may come into the throat, and when the patient is frequently clearing the throat and spitting, there will be blood. So that is spurious hemoptysis. Sometimes bleeding gum, gingivitis or oral ulcer, or bleeding from the tonsil, pharynx or nasopharynx. And iatrogenic, it includes dental procedures or oral trauma or upper airway trauma during intubation, instrumentation again can cause bleeding. And some pathologies like varices or telangiectasia of the oral cavity and upper airways. So these are the certain causes of spurious hemoptysis. And there are few peculiar causes where the bleeding is coming from the pulmonary circulation. And I have already told you pulmonary circulation or low pressure circulation, less likely they cause massive hemoptysis, but there are certain exceptions. So let us see which are the causes which are exclusively coming from the pulmonary circulation. The first is pulmonary artery aneurysm, where the artery becomes dilated and it is adjacent to the cavity or within the cavity. That can be considered as Rasmussen's aneurysm, or it can be some other fungal diseases where it can call it as mycotic aneurysm. And pulmonary embolism as well as infarction, basically the bleeding is coming from the pulmonary circulation. Whereas Swansgan's catheter is used for pulmonary artery catheterization, which is a gold standard for assessment of pulmonary hypertension and diagnosis. Whereas pulmonary vasculititis, again, the origin is coming from the pulmonary circulation. Acute on chronic lung abscess. If there is a lung abscess, which is chronically present in the lung, and there is an acute exacerbation. So because of the adjacent vessel erosion, it can lead to bleeding. And last but least is pulmonary AV malformation. So among these, pulmonary artery aneurysm as well as pulmonary artery venous malformations, they are having few chances of developing massive hemoptysis because the amount of blood is said to be more. So let us see few points about Rasmussen's aneurysm. You can see the Rasmussen's aneurysm. Aneurysm, you know the dilatation, okay? The dilatation of the vessel. And when you see there is a fibrotic tubercular cavity because of the destruction of the adjacent vessel wall, okay? The vessel wall will be dilated and it can be adjacent or within the cavity. So it is a pseudoaneurysm. It is not a true aneurysm. It is a pseudoaneurysm forming within or adjacent to a tuberculous cavity due to erosion of the arterial wall. So how the pathophysiology works here is it's a chronic inflammation where there is chronically destruction of the pulmonary arterial wall. So the elasticity, the muscular layer, everything will be damaged and leading to pseudoaneurysm. And once it ruptures, it may have a tendency of causing massive hemoptysis. So imaging in CT pulmonary angiogram, we can see there is a contrast filled outpouching in or near the post-tubercular cavity. So management, here we have to embolize the pulmonary artery. If not possible, and if it is localized, can be resected, then go ahead with the surgery. And if it is an active tuberculosis, you have to treat the tuberculosis. So this is a little brief about the Rasmussen's aneurysm. So coming to the massive hemoptysis causes. So there are certain straightforward causes which are having a tendency to cause massive hemoptysis. So first is bronchiectasis, which is including post-tubercular bronchiectasis because the circulation is coming from the bronchial circulation, which is a systemic artery, and damage to them is leading to massive hemoptysis. Fungal ball, of course, aspergilloma is tend to cause massive hemoptysis. Mitral stenosis, yes, it is shocking, but mitral stenosis tend to cause massive hemoptysis because I already told you submucosal bronchial vein, bronchial circulation is involved. Aortic aneurysm, yes, or large AV fistula, again, they are coming from the systemic circulation. Rasmussen aneurysm, just described, which is an outpouching and pseudoaneurysm, and pulmonary arteriovenous malformation. So these are few straightforward causes. There can be other causes, but these are straightforward causes which can cause massive hemoptysis, but not necessarily all bronchiectasis patients have to develop massive hemoptysis, but hemoptysis can occur massive in such patients. So let us see malignancy. So malignancy commonly causes massive hemoptysis is misconception in certain individuals where we think if it is a massive hemoptysis, we have to think of malignancy. So malignancy commonly causes massive hemoptysis is a kind of misconception because when you see the studies, it is around 3%. Okay, it is only around 3% it can cause massive bleeding. And usually those are from the central or cavitating tumor where there is invasion of the vessel or necrosis. Okay, otherwise it can present with a streaky hemoptysis. I'm not telling they will not have massive hemoptysis, they will have, but the chances are low when you compare to the previous causes. And these are happening only in central or cavitating tumor and there is an invasion of the vessel or necrosis. So that is the reality. So let us see how to approach a case of hemoptysis. So first thing, what I have told you in the beginning slides, you have to confirm the source of bleeding, whether the bleeding is coming from the lungs or the parenchyma or the tracheobronchial tree, or it is coming from the upper respiratory tract, or it is coming from the GI tract. So we should differentiate hemoptysis, pseudo or spurious hemoptysis, or hematemesis just by asking about the associated symptoms like cough, dyspnea, chest pain, or gum bleeding. We have to examine the oral cavity, we have to examine the ear, nose and throat for any bleeding site, and we have to ask about the history of vomiting and the color of the blood. So these are the clues which helps us to find or trace the source of the bleeding. Second thing, you have to assess the severity and stability. I have already told you how to assess the severity, and don't just go with the volume, just see the other facts. Whether the airway is compromised, the airway is obstructed, patient is having hypoxia, hemodynamic instability. Those are also very, very important parameters to assess the severity of hemoptysis. So estimated volume can differentiate between mild, moderate and severe. So in day-to-day practice, we can consider as teaspoon. If it is less than 2 teaspoon, it is mild. Up to 1 cup is moderate. More than 1 or 1.5 cup is said to be massive. Very important is, as I already told, airway, breathing and circulation, which if you see, if it is compromised with any volume, it is considered to be as a alarming sign or a red flag sign. And if the patient is chronically following up with you and he is having certain pathology on that side, so you can have an idea that, okay, if the patient is having massive hemoptysis, it is probably coming from the right side. So if the bleeding site is known, position the bleeding lung down in order to prevent the entry of the blood into the normal lung. So that is also one of the immediate thing which you can do in your day-to-day practice. Then after stabilizing, or if the patient is very stable in the OPD, you can go for a focused history, which includes the onset and duration. You have to ask whether this hemoptysis is occurring in sudden onset or it is there on and off, episodic, chronic or recurrent. And then you can go ahead with the quantity and frequency, like small streak or a large cup of blood. And associated symptoms like fever, cough, sputum, weight loss, chest pain and breathlessness in order to get a other differential diagnosis. Very important is risk factor. You have to ask the patient about the smoking history, tobacco chewing, occupational exposure, or travel to endemic areas for endemic infections. Very important, again, another aspect is past history. Whether the patient had a TB or a history of bronchiectasis or a cardiac disease, or he was having any coagulopathies, or he was on any anticoagulant for certain conditions, or he had any malignancy before. So all these past history is also very, very important. Recurrent or unexplained small volume hemoptysis with feature of pulmonary congestion may point to mitral stenosis. So mitral stenosis also has to be kept in mind when there is a massive hemoptysis and recurrent. Okay. And along with that, there is a pulmonary congestion. Physical examination is not having any specific sign for hemoptysis. It is same as for the other diseases. We have to start with the pallor, icterus, clubbing, cyanosis, lymphadenopathy and edema. And more likely, patient who are having recurrent hemoptysis are tend to have pallor. And if the patient is having associated bronchiectasis or lung abscess, they are tend to have clubbing. And if they are in the cardiac causes, then they tendency to have pedal edema. Respiratory system wise, inspection can be asymmetry if it is a post-TB airway, post-TB bronchiectasis, or surgical scars we have to see, or signs of any chronic lung diseases. Whereas palpation and percussion, if only there is consolidation or abscess, it can be dullness. And if it is bronchiectasis, on auscultation, we can hear bilateral leathery coarse crepitations. And sometimes there can be diminished breath sounds because of the consolidation or abscess. Cardiovascular, there can be mitral phases, loud S1 and opening snap, which are characteristic of mitral stenosis. And ENT or oral cavity, again, we have to examine the ENT and oral cavity to rule out spurious hemoptysis if there is a doubt of spurious hemoptysis. So every hemoptysis does not need a full workup. So please remember that in the first slide, which I had showed you, a streaky hemoptysis patient and a patient who is having half cup of blood uh, coming out as in the form of hemoptysis. So every hemoptysis does not require a full workup. Okay. So these investigations, they depend on the clinical scenario, the age of the patient and the risk factor. Okay. So when we should not go for extensive evaluation, if the patient is very young and there is no risk factor of malignancy or vasculitis, and patient is giving acute symptoms like fever, purulent sputum or recent infection, then we can think of recent infections like acute bronchitis or pneumonia, and also the bleeding is very streaky. Okay, you can wait and watch. You have to treat the cause, but ask the patient to review. It's not like you have to leave it. Ask the patient to review. Okay, if there is recurrent hemoptysis or the hemoptysis volume increases, then he might need a investigation, thorough investigation. But when to investigate in the first point of contact? When the hemoptysis is persisting for more than a week and is recurrent, and it has increased to moderate to severe in volume, and patient is a smoker for more than 40 years or has a high risk factors for malignancies, that is bronchogenic carcinoma, or when you are suspecting a diffuse alveolar hemorrhage, which can be of autoimmune etiology or a vasculitis etiology, definitely he needs a workup. And if the patient is having multiple bleeding sites, hematuria, bleeding gums, okay, so all those things you have to consider the coagulopathy or a systemic disorder. Or the patient is having associated cardiac features like dyspnea, orthopnea, paroxysmal nocturnal dyspnea, or opening snap. So in these patients, we need to evaluate mitral stenosis as a cause of hemoptysis. So these are the certain points where you have to think, yes, you need further evaluation. You cannot ignore the patient. You cannot send the patient with medication and tell him to follow up. So there are points where you can wait and watch. There are points where you need immediate intervention and evaluation. So what are the investigations which we normally do in a hemoptysis patient? Initial workup for all the patients is chest X-ray. First of all, to look if there is a true hemoptysis, then what could be the lesion, either in the form of an infiltrate or a cavity or a mass, that is a malignancy or a collapse of the lung or a bronchiectasis. Then we can go for blood investigations where we have to see for infections or any thrombocytopenia or anemia. And coagulation profile, very important for coagulopathies. And we have to check for other organs where the other organ derangement is leading, that is systemic etiology, and sometimes for pre-procedure. For example, before going contrast enhanced CT thorax, we should get the serum creatinine done. Sputum examination, definitely to check for, to confirm the infection, either in the form of a gram stain, okay, AFB smear or CBNAT for tuberculosis, cytology for malignant cells, and for fungal culture and KOH bond for fungal infections. And again, for pulmonary renal diseases, urine analysis is also very, very important. So these are the investigations which has to be done for all. And there are certain investigations which are done for non-diagnostic in the beginning phase or recurrent bleeding. So in that contrast enhanced CT or CT pulmonary angiogram, it identifies the lung parenchymal etiologies like bronchiectasis, cavities, and tumors in a better way compared to X-ray. And it also differentiates whether the bleeding is coming from the bronchial circulation or the pulmonary circulation. Second is bronchoscopy, where we can do it in a diagnostic way as well as in a therapeutic way. Diagnostic way, we can locate the bleeding site, and if we can biopsy, we can take it. Therapeutic, again, we can help in controlling the bleeding if it is a very massive bleeding. I'll be discussing about that in detail in subsequent slides. Special or the etiologic investigations include the ANCA profile or anti-GBM, mainly for vasculitis and Goodpasture syndrome, and echocardiography for mitral stenosis or any other cardiac condition, and angiogram, very important to identify the location. And along with that, we can also plan the embolization. That is either bronchial artery embolization or a pulmonary artery embolization. So CTPA, it is a one scan, but it gives answers to many questions. So it has many answers. So first thing, it will localize the site as well as the source of bleeding, whether it is a bronchial or a pulmonary. It also detects the underlying cause, whether it is a cavity or a bronchiectasis or a mass or any fungal ball or pulmonary embolism or vasculitis. All these can be detected on CTPA. And it also helps mapping the vessels before proceeding to bronchial artery embolization. The advantages of this is it is a non-invasive and it is done rapid and accurate, but it helps in interventional radiology, and it has an anatomic as well as vascular detail. and it is more superior compared to the other investigations. And especially when the bronchoscopy is not been possible, when the airway is flooded, CTPA can help. So limitation is patient needs to be hemodynamically stable. And especially I told you before going for a contrast scan, we should get a renal function test done, and it should be avoided in renal failure patients or allergy, because it can cause further worsening of these system. And sometimes if there is an intermittent bleeding, on and off bleeding, if you do it when there is no bleeding, it may miss. Okay, so I'll tell you what are those reasons. So this is a image of CTPA where you can see this is a pulmonary artery, main pulmonary artery, and there's a filling defect. Okay, so this is how the CTPA picks up the pulmonary embolism. So this is one image which is showing pulmonary embolism. Okay, so you can see here filling defect where the contrast is not able to reach because of the presence of the thrombus. Okay, so this is how the CTPA appears. So let us start with the management aspect. So if it is a mild or non-massive hemoptysis, like we have acute bronchitis or just pneumonia, so you have to treat the cause. So if it is a bronchitis, pneumonia, or we know the sputum has given AFB positive, CB net positive, tuberculosis, yes, just treat the cause. Either, and along with that, symptomatic medication. With the help of cough suppression, we have antitussives. I have already discussed in my previous webinar about the cough, how we divide the cough medication syrups. So among them, antitussives are used here, which are available in the form of syrup and lozenges, which can be opioid, non-opioid, depending on the patient selection. And we have tranexamic acid, which can be given in nebulized form, IV form, or oral form. And also, if the patient is on anticoagulant, if it is causing, then you have to stop and review. Okay, unless and until you are not sure it is causing, you should not stop. Again, reassure the patient, tell him to follow up after a few days, observe him, and then follow up. If the symptoms subside, well, wait and watch. If this symptom doesn't subside, if it increases, then you have to go for further investigations. So coming to the dosage of tranexamic acid, nebulized form can be given in 500 milligram every 6 to 8 hourly. And in intravenous, it can be given 1 gram, and then TID, 1 gram TID. And in case of oral also, it can go up to 1 gram thrice a day. So, okay. But very important is, if there is a renal dysfunction, you have to be very cautious. You have to be very cautious if there is renal impairment, as well as if the patient is having active thromboembolic disease. Then you have to be very cautious with the dose. In case of massive or life-threatening hemoptysis, first thing which I told you is you have to secure the airway, because patient may not die because of the loss of blood, but patient may die if that blood clot or if the gush of blood has gone into the airway and it is compromising the airway, leading to hypoxia. So secure the airway, continue the oxygenation, and simultaneously start with the large bore IV line and monitor the vitals. And already I told positioning of the patient. If the patient is chronically following up with you, and if you know the etiological site, then position the patient on the bleeding site in order to protect the opposite lung. And if the patient is having some massive hemoptysis due to anticoagulation therapy, there are certain antidotes present. Okay, so those antidotes can be preferred in these cases. And we have tranexamic acid, which can be given in the form of nebulized or IV as a temporary measure, to control the bleeding. So role of bronchoscopy in hemoptysis is very vital. Okay, so what does it do? It helps in localize the bleeding site. We can live localize the bleeding site, and helps in identifying the etiology, because we can take the sample in the form of alveolar lavage or biopsy and send it for testing and get a diagnosis. And also it helps in providing the therapeutic control simultaneously. The timing and the type. Okay, what is the timing to do bronchoscopy and which type of bronchoscopy? It depends upon the urgency. Flexible bronchoscopy are best for diagnostic use in stable or minor bleed or suspected malignancy, which is not having hemoptysis. You can use flexible bronchoscope. Rigid bronchoscope is used when there is massive ongoing bleeding, because it has an advantage of working channel. Along with that, the oxygenation can be done. So it is superior in suction, better visualization, as well as airway protection compared to flexible bronchoscope. So which are the hemostatic agents which we can instill through bronchoscope directly into the lung? So cold saline is preferred, which is maintained at around 4 degrees centigrade, which we have to use it in the form of 20 to 50 ml total around 400 to 500 ml. So because of this cold temperature, it helps in local vasoconstriction. So it is a very simple and first line and very rapid control. Okay. If not, then we have to go with the adrenaline in the dilution of 1 is to 10,000. Again, we have to instill 5 to 10 ml, but this has the side effect of increasing the heart rate and blood pressure. So this has a systemic side effect. Tranexamic acid can also be used, but it has to be diluted in 20 ml normal saline, and it acts as an antifibrinolytic. Whereas a hemocoagulase, that is a botropause, which again can be used in 2 to 4 ml. So these are certain hemostatic agent, but commonly preferred is cold saline. Okay, because it doesn't have any much side effects. What are the interventional bronchoscopic techniques? So there are certain interventional bronchoscopic techniques. The first is the balloon tamponade, where the balloon catheter is introduced and it is inflated in order to stop the bleeding temporarily. And it is used mainly for massive or localized bleed. Second thing is thermal coagulation, where with the help of electrocautery, these are advanced bronchoscope, where argon plasma coagulation or laser, NDYAG laser, they help to coagulate the visible bleeding sites. Okay. And last but least is the endobronchial application of the sealant. Some sealants come, and with the application of this, the bleeding stops. So these are certain interventional bronchoscopic techniques which are used in bleeding, which are localized and massive. Then comes is bronchial artery embolization. So this is a first line definitive control for bleeding, mainly from the bronchial circulation, because these are massive bleeding. These are massive bleeding, and that's why this embolization is a first line definitive control. But what happens is it has an immediate success. There is a tendency of recurrence. This emboli might dislodge and again the bleeding might start. So there is a chances of recurrence. So it acts as a bridging therapy. If there is a massive hemoptysis and patient is fit for surgery, so in order to stabilize him, we can go for bronchial artery embolization and then plan surgery, because we'll get a time duration. So there can be chances of recurrence. So repeat bronchial artery embolization is also acceptable if patient is not fit for surgery. If the patient is fit for surgery, if there is a localized lesion, okay, or if the bronchial artery embolization or the bronchoscopic control has been failed and it is a localized lesion which is ready for resection, then you can go ahead with the surgery like lobectomy, pneumonectomy, or segmentectomy. So surgery can also be reserved, but for that the patient has to be fit and it has to be localized disease and it is failed with the bronchial artery embolization and bronchoscopic control. What are the complications of hemoptysis? So I have already told you the patient will not have fear due to loss of blood. It is mainly because of the airway compromise. So because of the gush of blood going into the airway, asphyxiation or airway obstruction can occur, and that is the one of the most common cause of death in a massive hemoptysis patient. And because of the airway obstruction, the patient may develop hypoxemia and lead into respiratory failure. And sometimes it can cause aspiration pneumonitis and anemia and hypovolemia, mainly due to blood loss. Secondary infection. Blood itself is a nidus for infection. If it is present in the airways, it can act as a nidus for secondary infections. Electrolyte imbalance and metabolic acidosis due to severe blood loss. Yes, of course, it can also occur. And recurrence. Recurrence of hemoptysis, it depends upon the underlying etiology. If the etiology is some structural lung disease or malignancy, they tend to recur. Whereas acute infection, self-limiting conditions, they tend to subside with the treatment. And because of this massive hemoptysis, the patient will have a sense of anxiety, a sense of fear that he can develop massive hemoptysis at any time. He'll be under the fear. He'll be living under the fear that anytime his cough can trigger and he may develop massive hemoptysis. So psychological distress can also be one of the complications of hemoptysis. So let us see some special cases. So first case, a 28-year-old woman presents with recurrent streaky hemoptysis for around 6 months duration. And each episode lasts for 1 to 2 days, and it was tend to be matching with her menstrual period. On taking history, on taking focus history, this was found. But she denies again fever, cough, or weight loss. Whenever this 1 2 day of hemoptysis occurs, yes, then that time only there was a cough. After that, she was completely fine. And she is a non-smoker and she does not have any significant past history of tuberculosis or bronchiectasis. Whereas physical examination was completely fine. Routine chest X-ray was normal in between the episodes. And during one small episode, HRCT was performed. Okay. So CT was performed thinking that we'll go ahead with the contrast if there is any pathology. but contrast was not required because the pathology was very small. It was a patchy opacity in the right lower lobe. So what can be the diagnosis and why it is correlating with her menstrual cycle? Yes. So you guys are in the class. So that's correct. So it was coinciding with the catamenial or pulmonary hemoptysis where there is a ectopic endometrial tissue. So ectopic endometrial tissue, which is present in the lung parenchyma and that bleeds cyclically with the menstruation. So what is the clue? It synchronizes with the menses, and in between the episodes, it is normal. Whereas investigation, if you do the HRCT or chest X-ray during the episode, then only there will be transient infiltrate. And during the bleeding site, there can be chances that you can localize the bleeding bronchoscopically. So treatment was hormonal treatment. And if it is persisting, usually it will subside after the menopause. And if it is not subsiding, then surgical excision can be done if it is a very refractory. So this was one of the case. Then case two, a 14-year-old girl who complains of streak of blood in the saliva multiple times in a day. Okay, multiple times in a day she was complaining streaks of blood in saliva, and she does not have any cough. On repeated asking, she never said she was coughing, and upon asking the parents also, they never agreed that she was having a cough. And no fever, no breathlessness, no other systemic symptoms, no history of any tuberculosis or any drug use. Otherwise, healthy school-going girl, bright student. Even malingering possibility was thought. So that was also ruled out because she was very bright student. But on examination, they found to be oral cavity was having mild gum inflammation and bleeding was near the molar. Rest all came everything normal. So this was supposed to be a spurious or a pseudo hemoptysis due to gingival bleeding. So this was the etiology in this patient. Coming to third case, where we see a 36-year-old male who was an auto rickshaw driver, who was also a known case of bronchial asthma from 8 years, but not on any regular inhaler. He was using it on and off. And he was never a smoker, but a tobacco chewer. And he presented with a streaky hemoptysis for 5 days. But he does not have any fever or chest pain or weight loss. Initial finding, chest X-ray was having some infiltrates. D-dimer was sent, which was elevated, and lower limb Doppler, which showed a thrombosis in the saphenous vein. So hemoptysis, D-dimer is elevated, auto rickshaw driver, and lower limb Doppler showing saphenous vein thrombosis. Directly go ahead with the CT pulmonary angiogram. But in that, there was no pulmonary embolism. But it showed a minimal proximal bronchiectasis. So further workup was done because it was a minimal proximal bronchiectasis and history of asthma. Total IgE was sent, which was markedly elevated, followed by aspergillus specific IgE, which came out positive. So the diagnosis was allergic bronchopulmonary aspergillosis. So always don't think that not every hemoptysis with high D-dimer is a pulmonary embolism. In asthmatics, always think of ABPA, especially when there is bronchiectasis and elevated IgE level. Yes, high D-dimer can be positive in other conditions also. And though this patient had lower limb Doppler, saphenous vein thrombosis. So thrombosis, D-dimer, yes, tendency to think in the form of CTPA, but CTPA gave us minimal bronchiectatic changes. Again, retrospectively correlate with the bronchial asthma history. Send for total IgE and aspergillus specific IgE. We can get a diagnosis of allergic bronchopulmonary aspergillosis. He was treated with that condition and the hemoptysis subsided on its own. So let us see the final flow chart. A patient coming with the hemoptysis. You have to rule out spurious hemoptysis as well as hematemesis because you have to find out the location, whether it is exactly coming from the lung. Then take the history and do physical examination. Classify hemoptysis into non-massive and massive. Non-massive, if there is no risk factor, treat the underlying cause. If there is persistent bleeding, then wait and watch. If there is risk factor, then go for basic blood and urine test. Contrast CT or CT pulmonary angiogram, bronchoscopy, which helps in localizing the lesion and treat the underlying cause. If the patient is having non-massive, no risk factor, treat the underlying cause. If there is persistent bleeding, then again, you have to go for evaluation. If there is a massive hemoptysis, which I have already told you, first you have to protect the airway. If the bleeding stops, well and good. If it doesn't stop, persistent bleeding, then plan for surgery or bronchial artery embolization. Whereas if there is a risk factor, you have treated the underlying cause, still there is a persistent bleeding, then you have to think of surgery or bronchial artery embolization. So this is a flowchart how we have to go ahead in the cases of patients with hemoptysis. So let us go for a quick quiz. Okay, you guys are ready? Okay, so let us start with the quiz. A 40-year-old man presents with a streak of blood in sputum after a week of productive cough and fever. Chest X-ray showed right lower zone consolidation. What is the next best step? A, B, C, D. Refer for bronchial artery embolization. Anybody else? So we have to treat it as pneumonia because I already told you streaky and we know the cause. It's a localized cause. Okay, it's a localized cause. You have to treat and then wait and watch. Ask the patient to reassure, wait and follow. Okay. Which vascular system is responsible for most cases of massive hemoptysis? Yes, it's a bronchial circulation. That is a bronchial arterial circulation. In massive hemoptysis, death usually occurs due to yes, definitely. It is due to airway obstruction or asphyxiation. A 60-year-old smoker arrives with a cup half filled with blood. What is the first action? He is in massive hemoptysis. He is in massive hemoptysis. What is the first option? Yes, definitely. You have to secure the airway, and if you know the bleeding site, okay, the bleeding site has to be put down. The Rasmussen aneurysm occurs in which disease? Rasmussen aneurysm. Yes, it is a pseudoaneurysm occurring in and around the tubercular, post-tubercular cavity. Which feature helps you distinguish hemoptysis from hematemesis? Hemoptysis from hematemesis, I am telling. Acidic pH, hematemesis. Dark color, hematemesis. Presence of food particle, hematemesis. So frothy appearance goes in favor of hemoptysis. Good. Nebulized tranexamic acid dose used for hemoptysis. It is 500 mg in 5 ml. Okay. Which condition causes cyclical hemoptysis linked to menstruation? Yes, catamenial hemoptysis. Massive hemoptysis workup shows no pulmonary lesion. Patient had gum bleeding and petechiae. Likely cause? Yes, systemic cause, that is coagulopathy, because embolism, why they will have gum bleeding and petechiae. Correct. In approximately what percentage of patient with hemoptysis, no definite cause can be even found after complete evaluation? So certain studies have showed it is 20 to 30%, even though despite extensive workup, there is no cause. So those are called as idiopathic or cryptogenic hemoptysis. So key take home points are always confirm the source of bleeding before calling it hemoptysis. Okay, you should know when to call it as hemoptysis. Second, maximum cases are arising from the bronchial circulation. It is a high pressure circulation, so chances of massive hemoptysis is high. Common causes are tuberculosis, bronchiectasis, malignancy, aspergilloma. Massive hemoptysis, it kills by asphyxiation, not by the blood loss. So protect the airways first. CT and bronchoscopy are complementary for diagnosis as well as localization as well as for therapeutic purpose. And early referral for embolization can save lives if they are having recurrent massive hemoptysis. So this is a disclaimer. And this is a QR code for your feedback. And this is thank you. So doctor's greatest tool is not the stethoscope, but the ability to listen the patient with empathy. Thank you.
Thank you, doctor. Thank you so much. We are opening our Q&A session. Doctors, please put your questions on the chat box. If you want to ask anything to the doctor, doctor would be able to answer your questions. Uh, Sri Adharan says it's excellent lecture. Thank you so much. Um, we always try to bring you the experts to guide you and teach you and to mentor you. Dr. Madhumita Jaina says, thank you, sir. Dr. Pratibha Shukla says, thank you, sir. Thank you, Dr. Pratibha. Thank you, Dr. Madhumita. We have conveyed your thanks to sir. Ashish Shrestha, thank you so much. Dr. Dr. Anna says, thank you so much. Doctor, please drop in your questions. If you want to ask anything, any questions to doctor, you can directly ask. Doctor would be able to answer you. Or if anyone wants to come online, you can come and ask. You can just raise up and we will be able to unmute you. You can come and ask your question. Meanwhile, I'll drop the certification link. So please do go. Anyway, the QR code was also displayed. We will be sharing the link as well. Please fill the form to get your certificates. The certificates will be sent to you for next 2 working days, 2 to 3 working days. Please bear with us. Uh, Thank you so much for great session. Dr. Vinay Kumar Singh says. Dr. Farooq Ahmad says, nice session. Twinkle, one of our regular attendee. Thank you, Twinkle. Thank you so much. Whenever we have your attendance is marked. Yes. Thank you, Twinkle. Vijay Chavan. Thank you, Doctor. Thank you. So please drop in your questions. Doctor is here to answer your questions, your queries, any doubt regarding to the topic or Aditya Gupta. Thank you, sir. Thank you. Asutosh Rana says thank you. Okay. I think, Doctor, there are no questions.
Yeah, I guess I have tried to cover because hemoptysis is like anything you take in a medical field, it's very vast. You cannot cover in an hour or an hour and a half, and everything you learn by experience by treating patients. So I have covered almost majority of things, and I
Thank
hope whenever a hemoptysis patient comes, instead of getting scared, you will be able to manage a little bit.
Yes. We would also request you, like you said, it is not this topic to cover in one session. So we can have many more sessions on this. I think doctor would agree. Doctors, if you agree, please drop yes. So doctor would be able to plan for next section with the same topic with even more extensive discussion. Dr. Rohit Kakar says yes. Great. Doctor. Okay. So please
Yes.
do drop yes if you want to hear more about today's topic. Vivek says yes. Thank you, Vivek. We will plan if we receive more yeses.
Yes, yes, definitely we'll plan and definitely we'll try to bring more exciting such topics,
Yes.
especially from pulmonary medicine.
Yes.
So stay tuned with us and we'll definitely bring exciting sessions in future.
I'm also dropping our social media channels. Please do um, follow our channels to stay updated. Also, we have our WhatsApp channel, dedicated WhatsApp channel where you can get all the updates. So we are receiving a lot of yeses. Yes, Kanjana says yes. Farhana says yes. Thank you, thank you. We will plan. Please do. I have again copy pasting the certificate registration form link for you doctors to register yourself so that we can send your certificates. Please, one my kind request is to fill the form without failing because to get your certificates we need this registration form to be filled. I think there are no questions, doctor. I think we will will lead to the end part.
Yes,
uh,
yes, definitely. Thank you. Thank you, Vijay. Thank you, everybody, for the
thank
patient listening.
Yeah, thank you, doctor. Thank you for this insightful session. I would say this, I personally learned a great deal and I am 100% sure The doctors here would agree with me. On behalf of everyone, I would love to extend our sincere gratitude to Dr. Sohail Mohammed. It is this kind. I also the engagement in the session. It is this kind of sessions pulls us to do much more sessions like this, and we will continue to do this. Thank you so much for joining us today. Thanks a lot, and we keep follow our social media channels to know about our upcoming webinars. Thank you
Thank
so
you.
much.
Thank you, Vijay. Thank you very much.
Thank you,
Thank you,
doctor.
everybody.
Bye. Good night, doctors. Good night. I will be here for few more minutes. I am dropping again the certificate registration form. I would request each and everyone to go there, fill the form, and submit it, thus getting your certificate registration done. I can see there are almost already a lot of people filling the form. Uh, Before ending the session, I would request each and everyone to fill the form, thus getting certificates. If anyone want to come and share their feedback, they can. You can if you want to. Meanwhile, we wait for the registration form to be done. If you're not able to mute yourself, you can raise your hand. I'll unmute you. Cool.